Everyone. I would like to thank everyone for joining us this evening. I would also like to introduce myself. I'm currently the president of AAPIO and a practicing endocrinologist in San Jose. For this evening's talk, I would like to mention a couple of things. Our speakers are on the East Coast, so we would definitely like to be mindful of their time. It's already 9 o'clock for them. We will have both talks and then have enough time for questions at the end. Please feel free to type them in the chat box as we go along, and we will take as many as we can at the end of both talks. We have a large audience tonight, and I request everyone to mute themselves except for the speakers to avoid all the background sounds. Times are changing rapidly, and most of us are wary of what the future of healthcare is going to look like. Both of our speakers today are going to help us shed some light on this topic. The title for today's talk is Strategies for the Future of Healthcare in the Post-COVID Era. Our speakers for tonight are the esteemed Mr. Anish Chopra and a longtime colleague and friend, Dr. Rasu Shrestha. Dr. Rasu Shrestha is the Executive Vice President and Chief Strategy and Transformation Officer for Atrium Health. Previously, he served as the Chief Innovation Officer for the University of Pittsburgh Medical Center, UPMC. He received his medical degree from CCS University, Meerut in India, and went on to complete his training in radiology and his fellowship in informatics at the University of London. He also earned an MBA at USC's Marshall School of Business. In addition, he's on the board of directors of Healthcare Information and Management Systems and is the chairman of the HIMSS Innovation Committee and co-chair of Health Data Palooza. Mr. Chopra is the president of Care Journey, an open data membership service building a trusted, transparent rating system for physicians, networks, facilities, and markets on the move to value. He served as the first US Chief Technology Officer under President Obama from 2009 to 2012, and in 2014, he authored Innovative State, How New Technologies Can Transform Government. He serves on the board of the Healthcare Cost Institute, the New Jersey Innovation Institute, and earned his master's in public policy from Harvard Kennedy School and a BA from the Johns Hopkins University. And so without further ado, I'd like to invite Dr. Rasu Shrestha to start his talk.
Thank you, Archana. It's a pleasure to be here amongst all of you. I'm just going to start sharing my screen, and we'll get going here. Excellent. Archana, can you see my screen? Yeah, okay, excellent. Well, good evening, everyone. As Archana kindly introduced me, I will not delve into anything that I'm doing further here. I did want to let you know that I lived in California for about 7 years or so. We're in Los Angeles. I was at USC at that point, and my wife, who is actually from India, I'm originally from Nepal. So my wife, who's originally from India, did her radiology residency while I was in charge of informatics at USC. So she did her radiology residency there at USC, and then started her, finished her residency when we moved to Pittsburgh, and then did her fellowship in abdominal imaging at UPMC, where I was working there as well. So what I've titled my presentation today is just managing enterprise strategy amidst a crisis. And what I thought I'd do is just run you through some of how we as a large health system here in the Southeast are really thinking about some of the strategies related to COVID-19 and how we come out of this. It's pretty sobering if we look at the milestone that we hit April 28th, I believe, where in the United States we topped 1 million confirmed cases of COVID-19. And that's nearly a third of the world's cases. And right now, I think we're at about 1.3, if not higher already today. So what's uncanny is that we spend trillions on defense, yet it really wasn't a missile that brought down the world economy. So in many ways, COVID-19 should be an eye-opener for how we prioritize spending in public health. And one thing that has become apparent, and I think Anish might touch upon this as well, is that the walls between medicine, so this is where we all practice healthcare, and public health, the walls between those two domains have really come down as a result of COVID-19. And clearly, it's now more of a global pandemic, right? Something that started in Wuhan is affecting all of us all across the world. So geography really is, more of just a physical construct, and it's not an economic one anymore. So a lot of things I think will change. And in fact, the way we work, our business models, the very interaction with our patients will change, and they've already started to change from now on already. So lots of things going on. What I thought I'll do is I'll just quickly introduce Atrium Health and give you the context of the health system that I'm a part of. I'll talk about the current situation, and I'll talk a little bit about how we're trying to think through the elements of managing the strategy and how we're leading through the crisis. And I'll end with a couple of vignettes, talk about our COVID-19 virtual hospital and how that's going to lend itself to some newer care models. We just went live a couple of weeks ago with point-of-care ultrasound innovation that we took out a big press release actually just today. So we'll talk a little bit about that, and I'll end with some of the things that we're doing around communications and community engagement, which I think will dovetail nicely into Anisha's presentation. So Atrium Health, we're based out of the Southeast here, headquartered in Charlotte, here in North Carolina, about 70,000 teammates. But then we're also in South Carolina and in Georgia. So a lot of things going on across the three states here around COVID-19. We're about 50 hospitals and about an $11 billion health system. So a lot of different numbers here. I won't go through everything. This was pre-COVID-19, where we had, in this volume-based way of practicing healthcare that we're all in, good volumes. What's really interesting about Atrium Health, and this is all volumes depicted in one day within 24 hours, like all close to 40,000 patient encounters, so one every 2 seconds. But what's really unique about Atrium Health is the community mission that we're on. This is one of the things that really excites me to be a part of the leadership team here and to lead strategy. So $2.2 billion in uncompensated care and community benefits every year. And that's like 5.7 million in a span of 24 hours. So we do a lot of things for the communities to address social determinants of healthcare, the disparities in care. And in fact, if you look at the statistics across the Southeast here, there's a lot of disparities between the haves and the have-nots. And part of our mission at Atrium Health is really to solve for that, right? It is about health and hope and healing for all. And those last two words of our mission statement really resonates with a lot of the strategies that we've put in place. I've been here for about 15 months. And even in the last 15 months, been able to do a lot of things with the leadership team to push for the for all part of the mission statement. And that speaks also volumes of the continued strategies that we're putting in place post-COVID-19. So a couple of quick words about the current situation. We did manage to sort of flatten the curve. So we're expecting a big peak. It was meant to be in the middle of April, and we pushed it off to about the middle of May. And because of the stay-at-home restrictions and the shutdown and all of that, and lots of other things that we're able to do, we did manage to flatten the curve in large parts, and it's more of a plateau than anything else. You can see from just yesterday's numbers, however, that it's not going down. It continues to spike up or down, and so it is more of a plateau. And we're seeing that really across the three states here. Georgia has been hit especially hard, and the governor did decide to open up the tattoo parlors and the bars and all of the beaches and all of that. So we're expecting the spike to continue to go up in Georgia, and we'll see how things play out here in North Carolina now that the stay-at-home order has actually been lifted in a phase 1 approach as of May 8th. It's a lot of things going on, but virtual health, this was, a set of capabilities whose time had come. I talk about telemedicine as an overnight success story that was 30 years in the making, because we've been working on it. We've been, pushing forward with telemedicine. I'm a radiologist, so teleradiology, and we've been doing this for decades now. But suddenly, because of COVID-19, you could see the numbers just spike up in so many different areas across the board. So really remarkable. And here at Atrium Health, we're seeing those numbers spike up as well. And you can see some of what I've represented there. It was interesting. We're, on average in the urgent care virtual video practice, we had 23 on a daily basis in 2019, and we bumped that up to over 400 every day. So that was a 16% bump up. But when you add in all of the service lines, virtual video practices that we stood up, we went from the same day average of 23 visits to now averaging about 1,800 per day, which is a 7,500% increase in the system-wide video visits. And that doesn't include the virtual check-ins and the phone visits, which are even higher, and the e-visits as well as the e-consults. So really a lot of things happening in terms of just the bump up in virtual health. One of the things that we did early on was we quickly stood up an AI-powered chatbot in our website, in our digital front door, so our apps and all of that. And whereas in the first 24 hours of this, we had about 30,000 unique visitors, it has continued to rise up. And you can see close to about 700,000 chatbot users cumulative, and about 800,000 there in terms of cumulative sessions. It continues to rise up, which is just tremendous. And it was really helpful in allaying fears, but also helping with the triaging of our patients. And so capabilities such as these chatbot type solutions will not go away, and they'll continue to stay even moving forward. So how do you lead through a crisis? And when we think about strategy for a system as large as ours, I wanted to share with you some of our leadership fundamentals. And I think, one thing that I subscribe to is the fact that leadership is less about putting certainty out there, because in healthcare in particular, especially at a time like this, you cannot guarantee certainty. So it's less about certainty, but it's more about clarity. And I think clarity really is king. And so these are some of the leadership attributes that we strive for here at Atrium Health, and I think is really important. So humility, empathy, science, agility, resiliency, so really critical. So we obviously as a healthcare community did everything that we can, and you in California have been really leading the charge in a lot of the different ways to flatten the curve and to stop this sort of the death march that was coming at us from a national perspective. But just from a strategy perspective, so we think about, how do we pivot? How do we think about what's next? I wanted to break it down into three specific categories here. There's the financial elements, there's the access elements, and there's the operational elements. And this is essentially how we're thinking through. Financially, we as a health system are, like many other provider organizations, going through a lot of losses right now, and we're reevaluating a lot of our capitalization ratios and all of that. At Atrium Health, it's about $150 million of losses every month that we're going through this. So that's pretty dramatic given where we were previously. From an access perspective, we talked about virtual, digital health solutions will continue to be prioritized over anything else. One big strategy that we're pushing for here at Atrium Health that I'm working on right now is what we're calling our Connected Care Everywhere strategy. And that's essentially, in a nutshell, trying to put together a number of strategies that say, hey, what does care outside of the bricks and mortar hospitals really look like? And I think that's going to be really important post-COVID-19. And then from an operations perspective, work from home is now a reality, and we've essentially mandated that those of our teammates that can work from home should work from home at least until the end of the summer, and it'll probably continue at least until the end of the year. And perhaps that'll be the new norm, and we might continue to do that well into the next year. And so lots of things from an operational perspective as well. So I won't go into too much of the details. But what I did want to share with you is that I think what we're dealing with right now is really just that first wave. And there's going to be a first wave tail of the post-ICU recovery, a second wave of the impact of resource restrictions on urgent non-COVID conditions, because they didn't just suddenly disappear. So they're going to be coming back, and we're starting to see some of that now that we're starting to reopen some of our facilities and the electives from a selective perspective. And then this third wave of impact of interrupted care of chronic conditions, and perhaps a fourth wave of mental illness and economic injury and burnout that we're going to see the sustained over time. So a lot of things there from a strategy perspective, but the one thing that we did put in place was this framework where we immediately mobilized a war room, and we had a number of different parameters that we set up so that we could be a lot more nimble of an organization. And in many ways, decisions that took years sometimes to make were made within days, and that was really remarkable. So I'll quickly go through some three examples. One is our virtual hospital that we stood up in a very short period of time. And what was really interesting about this was at the peak of our pandemic, we were able to stand this up just within a matter of a day and a half. And that was, I think, quite remarkable. Over 1,500 patients have received care in the virtual hospital since the opening in March 24th. And to support patients in their home environments 24/7, which was the goal out of the virtual hospital, so we could keep patients that did not need to come into our ICUs and into our hospital beds, we could keep them at their homes, right, and monitor them digitally. And that was essentially the goal of our virtual hospitals. And this was sort of a coordinated effort across so many different areas at Atrium Health. And essentially what we did was we were able to then have 2 virtual floors, each staffed with care teams that included physicians and APPs and nurses and PharmDs and social workers and paramedics. And it was quite remarkable. And here's what we did across the 2 floors was we had the first floor essentially dedicated to patients with limited symptoms, not requiring inpatient care. And then the second floor, you can see my air quotes here, were patients that required inpatient level care, but not necessarily critical enough to be admitted into the ICU, where again, we're monitoring them remotely with their oxygen saturation and blood pressure and temperature and a number of other parameters digitally. And that care management navigation across the continuum was what we're managing on a day in, day out basis. So it was really helpful. The results were remarkable for us, and we're able to really manage our bed capacity very effectively from this. And I think this is here to stay. I think what we're going to do is continue to push this forward and imagine the next big hospital for Atrium Health to be a 1,000 or a 10,000 bed hospital that essentially are patients' homes and the beds that exist in their hospital. So monitoring them remotely, leveraging digital and population health fundamentals to really risk stratify our populations, but manage them where they eat, work, live, and play will continue to be a strategy that we'll continue to push ahead with. Very quickly, a couple of words on point-of-care ultrasound. So this was really interesting. I'm a radiologist, so we've been proudly social distancing since 1895 is what I like to say. So it wasn't difficult for radiologists when social distancing became a norm for us almost. But joking aside, what point-of-care ultrasound is essentially this, right? So it's a probe that's connected to your iPhone. And we're the first major health system to go live with this in an enterprise manner, and we're able to turn this on in the last couple of weeks, and it's been really beneficial. The 3 things that I've always been pushing for around POCUS or point-of-care ultrasound is size. I wanted for these devices to be portable and really a part of a smartphone. So the many times that I was trialing out portable ultrasounds in the last several years, the size was too big. Price point, oftentimes 10,000, 20,000. I wanted these to be less than 2,000, which is what these devices are. And I wanted AI to be present because these are not just being utilized by radiologists. In fact, it's primarily being utilized by ED physicians, cardiologists, our anesthesiologists, our paramedics, nurses, and others in the front line as well. So this is AI powered in many ways. So it's quite remarkable. So it had all three of those specific elements. Here's a patient being scanned with all of the PPE. So we're able to look at things like pleural effusion, lung opacities, lung consolidation, pulmonary edema, and this is really the portability of it was what really brought to bear the benefits, and then the ease of cleaning, and then obviously the throughput, so that we could quickly move our patients, COVID positive or otherwise, through our EDs, ICUs, and pop-up clinics. So let me try to move to the next slide here. Sorry, as my presentation freezes. Excuse me.
This is a lung ultrasound study in a patient with confirmed COVID-19 infection. We're in a lung preset. We see a rib here with a shadow.
I'm going to skip to the next slide here. That was just an ultrasound, a lung ultrasound that I've done on a patient here. So lots of positive feedback, both from the front line as well as, again, this is a strategy that we're going to continue to expand across the enterprise here. And I truly believe that point-of-care ultrasound will be the new stethoscope. And we'll have a lot of different use cases. We're going to actually build out a new medical school here in Charlotte soon, and in the white coat ceremonies, I'd like to give out these POCUS devices to all our medical students. So lots of amazing things coming yet. I'm going to end with just a couple of slides in terms of how we're managing communications and some of our community benefits. This is a quote from Mary Curie. She said, "Nothing in life is to be feared, it is only to be understood." And I think at a time like this, this is really important, and communication can be your Achilles heel, or it can also be your biggest ally. And one of the things that we've been able to do in the last year that I've been here is really align our communications group with our data and analytics group with strategy. And so we do a lot of studies in terms of what are our consumers saying, right? So design thinking exercises, but really also specific surveys and studies. And we found that there were a lot of concerns about the economic consequences, about, is there enough testing being done, and are there enough ventilators and tests? And so a lot of things there. One of the things that we decided to do some weeks back as we were planning for the reopening was we said, we're going to put a number of things together around what we're now branding as COVID safe. And this is a visible badge that's available in our digital elements as well as in our physical footprint. And it provides a level of reassurance, which I think is what our patients and our communities really need right now. And behind this badge are a number of things that we're doing in terms of some of the things that I've outlined here and more that provide reassurance to our patients and our communities that we're doing the right things. So as we're opening up our facilities, and as we look at some of the sort of the long tail of the pandemic in the next year or more, as we await the vaccine and perhaps the herd immunity elements, I think things like the COVID Safe initiative is going to be really important. We're continuing to obviously spread the message, both regionally as well as nationally and beyond. So a lot of our clinicians and our leaders continuing to spread the good word. And we're doing a lot of things internally as well, right? So I think that's important as well with 70,000 teammates. So using apps and digital platforms to really spread the word internally and make sure that we're able to communicate. And then from a regional perspective across our communities, doing a lot of things there, whether it's around the remdesivir trial that we're leading, the number of things that we're doing to serve the underserved and the minority communities here across the Southeast. So there you see these buses that are going around, work that we're doing with the YMCA. And we're leveraging fairly fancy analytics and geo mapping and geolocation, GIS technologies to look at these hotspots and essentially send these buses and serve the communities with COVID-19 testing and more. And then a number of things that we're doing around antibody testing and such. So a lot going on, but I'm going to stop there and then hand it over to Anish, because at the end of the day, it is really about not just what's happening in health systems, but also at a national level. And I don't see anyone better than Anish Chopra to give us insights into all of that. So Anish, all yours.
It was amazing. Thank you. I will pass the baton if you, I think you share and I'll grab.
There we go.
I very much appreciate it. And Archana, thank you for the invitation. I know these are difficult times, and I very much appreciate the chance to share a few minutes with you as we contemplate next steps in the healthcare delivery system. I want to begin by just saying, thank you for you guys for even organizing the session tonight. The sort of Indian American community, South Asian community had been a big part of my life, throughout my career in government, and just grateful for the opportunity to give back. And if there's anything I can do to be helpful, please do not hesitate to ask. What I'll do is pick up almost exactly where Rasu left off, and to share maybe more from a policy perspective where, as a nation, we're grappling with the healthcare crisis. While we are looking to open up, I wanted to point out a very critical failure in the system today, and that is the lack of the underlying information necessary for public health investigations. When the first round of COVID positive patients were reported, the CDC published in March a report on, I think, sort of 4,000 plus patients. And I wanted to point out a headline in the article that was a bit shocking to me, having spent a decade in the public and private sectors to modernize the system. Quote, "No data on serious underlying health conditions were available. Data are preliminary and missing, whether or not the patient was hospitalized, whether they were admitted to the ICU, whether the patient died, and even, unbelievable to me, what the age of the patient was that was COVID positive." So it is a bit of an abysmal circumstance whereby the healthcare delivery system has invested $35+ billion over the last decade, and yet most reported cases to public health were coming in through phone and fax. We are now entering this next phase where we need access to information in order to make granular decisions about whether we're going to open up elective surgeries or not, we're going to open up the economies or not, and community organizations like COVID Act Now and others are springing up to try to fill in the gaps with as much information as can be made available, both for policymakers and, frankly, the public. I won't spend too much time on COVID because I think Rasu did a nice job describing the provider perspective about the nature of the challenge. I'm going to lift up more broadly about where we were going in to COVID. And that is a crossroads on the healthcare delivery system. As I think many of you know, both political parties want to constrain healthcare inflation to something equivalent to GDP plus zero. That's a bipartisan commitment. And having served as Chief Technology Officer, part of the argument is that we need to reinvest the savings that would come from a slowing growth rate in healthcare into American competitiveness. So if you were to look at the industries of the future, many of which are technology-driven or data-driven, you'll learn that our competitors globally are out investing the United States, and that is causing great concern in Washington. Now, having said that, there is this small coalition of the willing. We'll see how big it is. Maybe some of you on the webinar tonight are in this camp, but the argument is that we need to find a way to open up our, more importantly, find a way to deliver higher value care at lower cost. For those of you who have been following the value-based care movement, there's the perception that, this is achievable, that, whether it be Don Berwick's study about waste at 30% or it be any other reports that have been out there, there is this sense that we can have our cake and eat it too. We can improve quality and lower the rate of inflation. On the methods, if you will, it's pretty straightforward. We're going to open up as much information as we can about the delivery system. We're going to tweak the financial incentives so we can reward better outcomes. And we're going to empower consumers and the organizations with whom they trust to better navigate the delivery system. And the goal is, if we do this at scale, we're going to have lots of experiments, rapid prototyping, rapid validation, and then hopeful scale of what works. We are aware, I'm in this movement, by the way, so you can imagine I'm a card-carrying member of this. Maybe it's a religious faith. I don't know what it is. There is a dose of reality that we have to acknowledge. That is some of the shining lights examples on how to do this. The Camden Coalition, the MacArthur Genius fellow that was at the heart of the movement, published results earlier, late last year, maybe earlier this year. I can't remember the dates, but where a proper randomized control trial was run. And unfortunately, despite all the wishful thinking that the models about going after the very sickest of the sick, tackling their social needs and a variety of other factors, the hope that that was going to be enough, ultimately we suffered from the traditional economic problem, reversion to the mean. So when asked about this, the CEO of Geisinger, Jaewon Ryu, an organization I'm very proud to work with, was asked by the podcast hosts, we've been betting pretty heavily on value-based care. What happens if this move to value doesn't work? What if there's sort of a mass exodus and physicians just say, you know what, I'm done with this? The answer is exactly where, those of us in the movement are at. And that is, I really hope we don't get there. If we don't, the alternative is draconian land, as Dr. Ryu said. And draconian land basically means healthcare on a budget. We're going to capitate. That could mean Medicare for all on the left, and it could mean Medicaid block grants on the right. And it'll be more about cutting the rates without any real underlying change to the delivery model. So we've got to avoid this. So what I'd like to do is spend the next, maybe 5-10 minutes walking through the argument about how we're going to get there if you wish to be a part of this movement. Number one, open data must be enabling infrastructure. Now, I don't know how many of you liked this, but back in the Obama administration, we changed a policy which meant that any person in the country can look up any of you and to find out exactly how much money Medicare paid you. So this is the Wall Street Journal's website. I searched the highest paid doctor, and that was, I blanked the name, but it's actually it's an Arizona-based doctor. And what we, the nature of the opportunity is you could sort of see the reality. This doctor was paid $11.1 million from Medicare. It wasn't in the traditional visits. It was about $8.8 million because this particular doctor injects essentially Eylea or Lucentis at about $2,500 an injection, when the $50 compounded version of Avastin was deemed by the National Institutes of Health as clinically equivalent. So shining light on performance will start to help people. Imagine you're a senior, you don't have a Medicare supplemental plan, you have to pay 20% of the coinsurance, your doctor tells you that you're going to lose your eyesight and that there is a way to solve this. We'll inject your eye, and God bless America, that's really, really important, but may not explain all the options, and that you could have had a 20% copay on a $50 injection versus what is today a multi-billion-dollar market. In fact, I wrote a white paper for any primary care doctors on the Zoom tonight. 25% of Medicare ACOs that failed to earn a shared savings check but made Medicare some money would have gotten a check if only 15% of the patients that needed the injections got Avastin instead of Eylea or Lucentis. Imagine the millions of dollars of bonuses that would have gone to primary care doctors if only a fraction of the patients under their responsibility were navigated to a lower cost option. Similarly, Medicare is opening up data. There's a 4-to-1 return on investment if you take a pre-diabetic patient and you enroll them in the YMCA Diabetes Prevention Program. Rasu mentioned his work with the YMCA. The results were so overwhelming. I put out this $1 billion innovation challenge before I left the White House, and this was one of the winners of that grant project. The results were so incredible. In 2018, every doctor in America could prescribe a free voucher to get the YMCA's diabetes prevention program. Hundreds of thousands of patients would be eligible, 4-to-1 return on investment, an absolute no-brainer. And guess what? Despite the results, instead of hundreds of thousands of patients getting the benefits, only 200 plus patients nationwide were enrolled in the program by the end of 2018. That number's gone up. We're now probably closer to like 800, but not 800,000, 800. Lastly, shining light on the system is helping us understand some of the bizarre documentation and billing gaps. When you switch from Medicare fee-for-service to Medicare Advantage, the financial incentives change a little bit in that there's more value in accurately recording the severity of illness on the patient who's now moving into a Medicare Advantage program from fee-for-service. That arbitrage has been a huge source of debate. That is to say, the patient's just as sick as they were last year as they are now, but because we never documented it in the traditional fee-for-service setting, no incentive to document it, we created a financial windfall for the Medicare Advantage plans who simply had the benefit of rewarding accurate documentation. Last year, Medicare Advantage data was publicly available for the first time. Care Journey, the company I run, we have a license to all of this underlying data. So we asked the question, who were the patients that flipped from fee-for-service to Medicare Advantage? And just what did we learn? We found a cohort of 600,000 people who flipped, and the prevalence rate of those who flipped, the rate of morbid obesity in that population doubled in 1 year. Now, I don't believe they were, going to In-N-Out burgers or whatever you all eat out on the West Coast, but clearly the documentation gap, that translates into thousands of dollars of revenue to the Medicare Advantage plan per patient that gets this sort of upgraded diagnosis. So this is where we are on the open data movement. And if you could throw tomatoes at me through the video, I'm sure many of you might. We are entering the era in the Affordable Care Act that called out that the reason Medicare would release this information is to encourage the development of rating systems so consumers can better navigate the delivery system to doctors that deliver high-value care. We are very early in the ability to use this data in this way, but we, Care Journey, are committed to doing so in as open and transparent a method as possible. I blanked the name of this orthopedic surgeon, put my name in there. This is an actual physician. This represents how well that physician performs on certain cost and quality measures as benchmarked against their peers in the geographic region in which they practice. This particular physician is reasonably effective when it comes to joint hip and knee replacement surgeries. But when it comes to the hip and knee replacement surgeries except the joint, much fewer procedures done by this surgeon, much higher costs on a Medicare population relative to what his peers were looking like in the same geographic market. Now, all the research questions that are out there, what is the appropriate risk adjustment and how do you factor in social demographic factors? All of those questions are appropriate, and we're entering the era where that debate will happen. The public will have access to this information somehow or another, which leads me to the main event. Those of us in the delivery reform world, we've tinkered around with managed care, HMO or not. We've tinkered around with ACO models and incentivizing physicians. There's really, a few options on the menu left that we haven't fully explored as a country. And one of them is to equip consumers using the smartphones that they now have in their pockets with the kind of supercomputing navigation decision support so that they can make smarter decisions along the way. If my family members qualified for the YMCA diabetes program, I would like for them to ask for the voucher and get the service and hopefully stay healthier without having to go full bore diabetes and need all the intervention. That's why the government, ONC and CMS, have regulated that all of these systems have to be made open to the individual patients. So you could see the rise of Apple Health, the requirement that all health plans, government-sponsored, and all doctors and hospitals have to connect if a consumer wants it. And you can ask the question, is this going to cost me an arm and a leg? This has got to be really difficult. Apple keeps a list of every doctor who's live on their system. And the very first doctor listed is Richard M. Adams of Family Foot Care of Texas. Now, Rasu, he's not a billion-dollar health system like Atrium, and yet he found a way to make it happen. I don't believe this is going to be very expensive. The headline here is that over the next 12 to 24 months, these new rules that the government has imposed will mean health plans have to push out information to consumer apps. Physicians are going to have to make available the information to consumer apps. And the infrastructure that would facilitate the consumer data sharing can be and will be repurposed to strengthen the payer-provider data sharing, which has been such a hassle so far. Now, in California, every primary care doctor today can apply to go basically full bore capitation for Medicare fee-for-service. It's a program called Primary Care First. It goes live next year. Applications were due. I think they're coming up now. And you can see that CMS is going to move away from the traditional fee-for-service medicine and really create more of a budget and a per kind of a monthly fee, a stipend, and to help get organizations driving. This program invites private health plans to join Medicare. And I don't know if any of you have applied for this service, but I'm excited to see what you may do. From my vantage point, it's about hug a doctor that's taken on capitated risk. In California, that's been long-standing truth. We've got to understand what it is that we can do to practice medicine in this new way and scale it as rapidly as possible across the country. Last couple of points. One, nothing in this next chapter of healthcare will work unless we earn trust. Consumers have been asked, who are you willing to trust with that information? Is it going to be Apple and Google? Look at them at the very bottom, tech companies, 11%. I don't think so. I think the applications they'll trust are going to be the applications that are given to them by their physicians. Overwhelmingly, 72% trust for physician data sharing. In my view, this new era of consumer-centered delivery will be anchored by a trusted application that operates sort of like a health information fiduciary, an organization that is critical to assembling all your medical records, working with your physicians, and providing for you the kind of decision support that's needed to make a difference. I'll end with this. You may hate your EHRs, and I'm guessing for many of you, that is like a four-letter word. We are entering an era beyond the EHR. We are going to now see the development of apps, just like we can download apps on our phones to delight our family members for photos and videos and movies. We too will see an era where doctors can download apps that help them solve their immediate needs, and they don't have to make a gajillion-dollar investment in this crappy EHR system that's been regulated for the last decade. This is an area where you'll see a great deal of innovation. The American College of Cardiology has open sourced the Million Hearts calculator. I worked with a team at MedStar to build a free calculator that doctors can use. Over 1,000 physicians in Maryland are now automatically computing the 10-year risk of a heart attack and enrolling patients in delivery models as a result. CMS has allowed every doctor to download all of their claims history for every Medicare fee-for-service patient they treat. And in Rasu's backyard in North Carolina, the governor has put in a new Medicaid program anchored around improving social determinants of health. And we've open sourced an app that would allow for physicians to screen patients and to make that screening information interoperable. So I went long, apologies for that. But Archana, I'm excited to engage in a bit of a dialogue if that was helpful information. And as long as I didn't scare anybody, I'm keen to be helpful. I see some of these typed in here on the start, but I'll defer. Rasu, you and I can go back and forth, whatever we make sense.
I'd like to thank both of you for the wonderful presentations and taking the time to come and spend with us. I know both of you are extremely busy, and we really appreciate it. let me see. There are a few questions here, and I'll read them out, and you guys can decide who wants to take it. One of them is, are physicians being trained on the point of care ultrasound? Russell?
Yep. So I can take that on. So the answer is yes. What's really interesting about training as it relates to point of care ultrasound is that it's really simple. So it's not years worth of radiology training and fellowships and all of that we need to go through. It's actually pretty simple. So we're working with the company. The company's name is Butterfly, and lots of online modules that are available, but also on-site training that we've made available, and pretty short courses at that. So depending on the proficiency level, we tailor them with these specific courses. So physicians are loving it with very little training. If at that, they're able to go in and start utilizing the devices. What's also interesting is that I mentioned AI. So there's AI algorithms that's built into many of the presets as well. And much like your iPhone, there are updates and newer algorithms that are pushed to you as well. So that makes it easier. That helps you, especially for a non-radiologist, helps you with some of the more complex type of or imaging type procedures. And there's also teleguidance. So someone could be guiding you virtually from another location as you're doing this ultrasound, leveraging the point of care ultrasound device.
There was another question that was also, how did telemedicine help in New York? Was it used for tracking? Let's see.
Let me make a statement about telemedicine more generally. I would not, let me separate out how physicians and hospitals use telemedicine from the public health departments. Contact tracing is really a kind of the responsibility of the state government. And so they have tools they use to communicate with people and to track them, investigations, if you will, about who and how they've been in contact. I would imagine the telemedicine use cases, Rasu, you could probably speak more about them, but I'm going to guess that for patients that are at risk of disease progression that can't come into the hospital, they're using this. Rasu, you could probably finish the statement. What else are you seeing on these?
Yeah. So a lot of things there, synchronous, asynchronous type telemedicine events. So, we're doing a lot of things right now in terms of teleradiology. But the most simple one was telephonic visits, not even video visits, but telephonic visits. And that was one that saw a big spike up with, us going into the COVID-19. So both in New York and our institutions here across the Southeast, that was what was the biggest spike up, was just telephonic visits. But the video visits element went way up as well. And but the other thing that's going up, and this is primarily as a result of some of the billing codes that are being turned on right now, are remote patient monitoring. And I think that's a really promising element of telemedicine moving forward that I think will be sustainable in the post-COVID-19 era, where we'll be monitoring patients from home, so much like the virtual hospital at home program that I talked about earlier. We now are actually going to be paid for some of these specific billing codes. So that's really exciting as well.
If I may, Archana, I see a question that I was keen to answer. Pankaj is asking, do we know the demographics and comorbidities that correlate with COVID mortality? The unfortunate reality is we are relying today on Wuhan and other Italy models. US models of mortality prediction have not really had the opportunity because we've not been able to assemble the data. It's not been published yet, and that's sort of a little bit of why I made a little joke on the chat, although this is obviously not funny. But the VA just shared verbally some early results on veterans, and they looked at factors that drive mortality. Obviously, number one is age, so that's obvious. Multimorbidity is also relatively obvious for the folks who dig into claims data. The Charlson Comorbidity Index scores of 8 would be a factor. But it turns out smokers and non-smokers are equally at risk, but former smokers are considerably higher risk. Former smokers. And also odd, if you drink a lot, you have lower risks of COVID mortality. So there's some very interesting factors that are coming out. And Pankaj, I don't know, 14x mortality is not what was published. So this is an area where the data needs to be more transparent. And unfortunately, we lack it. The public health department just basically knows the minimum in the case report forms that are phoned and faxed in. In Chicago, I am advising the governor's office, the mayor's office. Pankaj, your experience at Kaiser would be different than the experience at the VA. Isn't that sad? You're able to see the integrated data in your environment. They share the exact opposite on their presentation to the FDA this week. And this is the frustration. You have a sample, they have a sample, and it's completely different on the outcomes. And so that's an unfortunate circumstance, Pankaj. He's describing here that Kaiser's got a database to track it, and we're not seeing the same factors. And the reason this is frustrating is we're trying to aim as many limited resources to get folks quarantined, stay at home, and et cetera. And if we don't have the right outreach plan, we may miss the mark, and that's one of the frustrations. But back to my statement about the Chicago, the mayor's office declared that EHR records are the minimum data necessary for public health investigations. And now in Chicago, they have aggregated 50,000 medical records for patients that have COVID positive or negative, and they're beginning to comb through it for these sorts of factors. So that, Pankaj, in your example, that would be Kaiser sharing it with the local health department, pooling it with the other health systems, and then publishing their own investigation reports.
There's another question here, which is a little different. It has, how much has the lack of initial testing hampered what we know about COVID, and how do we safely move forward from here?
I'll defer to Rasu. I mean, we are all in the same boat. We should be doing more testing in order to understand what you need to do to make incremental decisions. A massive decision like shut down the entire economy for 2 months, that's a big, blunt instrument. We're going to move into a phase where we're going to have these more surgical interventions. When does Atrium decide to do elective surgeries, as an example, Rasu? Maybe you could talk a little bit about how you're thinking about the judgments that have to be made at the micro level.
Yeah, no, absolutely. So we were late as a country to start, testing, and we continue to be late in terms of the mass testing that needs to be happening right now. You might have heard that Wuhan is testing everyone across their communities right now, and there are many countries internationally that are doing that, but not in the United States. So we're late, and I think every day that we're late, what we've lost is opportunity to really get ahead of this. And as a result of that, we are where we are in the United States today. One of the things that we've done at Atrium Health is to try to, work against the tide and to do as best as we can to manage, the testing elements of this because we have our own lab. So we've got a fully functional lab internally. We were a little strapped initially because of the reagents that were lacking, and we had to depend on supply chain efficiencies to get that in place. But that that's my reaction in dismay to sort of the state of where we are in the United States as a result of our lapse in really jumping to the opportunity to test. Anish, just on the electives, we've actually started to turn back our electives in a very thoughtful manner right now. So we're starting to see our volumes start to bump up, and so specifically, having targeted outreach to patients that are more critical, that that need to come in. So for specific procedures, and so we've started to see that, and that's going to be ramped up in the next couple of weeks as we move forward.
I've seen that you guys have been answering a lot of questions on the side as well, which is really good. There was a question about telephone visits being reimbursed in the future. Will that still remain?
I certainly hope so. I think the genie is out of the bottle, and we're starting to have a lot of those conversations both at the state level as well as at the federal level. And a lot of the conversations that I've been having indicate the fact that payment parity will continue after this pandemic is behind us. It's also a culture change issue. It's not just one of policy and regulations. And what we've seen is there is a tremendous demand from consumers who've gotten used to this. And then same thing for the clinicians as well. Even the most technophobic clinicians were pleasantly surprised when they were able to do telephonic visits to their patients as a result of the restrictions that we put in place around COVID-19. And they're chatting with me and saying, "Hey, Rasu, this is actually pretty efficient, and I'm able to check on so many more patients as a result of this." So there's this cultural element that I think also would add on to the element of that genie being out of the bottle that I mentioned.
Thank you, Russell. Does anyone else in the audience have any questions that they would like to unmute themselves and ask? Please feel free.
I had a question for Rasu about certification COVID-19 free and his thoughts on UVC lamps. Is that something that anybody has thought of? There's ideas coming that you could things that we use every day, like our stethoscopes or even the ultrasound. If it's a handheld things that we're carrying around, would all need to be sanitized in some way. So, is UVC something that you've looked at or thought of?
Yeah, absolutely. That's actually something that we're doing in limited ways across several of our facilities here. When I was at UPMC, we'd actually developed a robot that would go into a room and, leveraging UVC, sanitize the entire room as well. So there are those technologies and capabilities that we have access to, mostly for our hospitals in the urban areas. But absolutely, that's something that we're continuing to push ahead with.
I think we've covered most of the questions that people have asked.
Question?
Sure, go ahead, please.
A question for Rasu. Really enjoyed your talk. One of the new norms that we're seeing in the hospitals is a lot of the hospitals are relaxing some of the rules, the stringent rules that we've had. Do you see a time where some of the allied health professionals will be a little more, such as doing ultrasounds on the patients, or even dialysis technicians and so forth, using the ultrasounds and feeding the information to the treating physician or surgeon?
Thank you, Srinivash. That's a great question, and it's one that hits home as a radiologist, because there's always turf battles going on across various groups, not just within departments, but also, like you said, between physicians and allied health professionals. The answer to that is yes. I think there's going to be more and more where PAs and others and allied health professionals, as you put it, will continue to eat into some of the things that we as physicians were or have been doing, primarily because it's just more of an economic equation than anything else. And I think what's important is for health systems, whether it's hospitals or clinics or otherwise, to closely monitor that movement to make sure that what's happening there still maintains the quality as well as the outcomes to the level that we would expect as a health system overall. But the reality is that if you look at anesthesiologists, right, PAs were able to go in and and there are arguments to be made on both sides, but in large parts, PAs were able to take in and do some of the the more mundane, I would say, type of tasks that were being done by anesthesiologists. But we're starting to see that in other areas, ED physicians, even primary care physicians and others. So that battle will continue on. I think personally, it's important for physicians to monitor that carefully, and there needs to be more of a collaborative care approach around the patient, with the patient in the center. But I think this is less of a policy or even a hospital decision in terms of how we do things, but it's more of an economic decision.
Thank you.
Does anyone else have any questions, suggestions, comments? None? I was,
I do have.
oh yes, please go ahead.
Sorry, this is Indu. I wanted to know, how do we, there's been so much institution to institution discrepancy on how PPE is utilized, and there's been a lot of focus on providing PPE in the emergency departments and the ICUs and in the inpatient setting, and rightfully so. But as we open up primary care offices and we start to see some of our patients in the office again, how do we protect the people that are coming in, that may not tell us that, oh, the dad of this kid just tested COVID positive, because they don't want to be told, okay, well, then you need to wait another week. And so how do we appropriately utilize PPE going forward, and how do we eliminate the discrepancies?
Yeah, I'll start. Anish, feel free to chime in as well. But I think what we need to do, and this is the approach that we're taking across our institutions here in the Southeast, is masks for all, right? When you're going into a hospital or a clinic or an ED or anywhere for that matter, you just have to assume that that patient may have at least exposure to COVID-19. Yeah, because there's just so much unknown about this, more than what's known, right? So it's not just those that have tested positive, it's also those who might just be carriers, and those who maybe have lower immunity. And there's just so much to be I think, unearthed here. So for us, what we're doing is we're being overtly cautious, and we're pushing for masks for all. Now, there are other elements of PPE that I think we need to account for in providing care, and that's something that we're factoring in as well. So just being, again, overtly cautious is what we're doing. One thing that I'll point out is just in terms of best practices, because one of the questions, or the angle to the question you asked was, there's so many different ways of thinking even across different institutions, even around PPE and such. They're emerging bodies that are coming together to share best practices. And one that I'll share with you is what's called the COVID-19 Healthcare Alliance. I'll put a link to that on the chat window here. But it's an alliance of different healthcare institutions and different companies. So Epic and Allscripts, startup companies, Google, Microsoft, but also Johns Hopkins, Atrium Health, many others are part of the coalition, and it's free to join. But there are tons and tons of resources and best practices that are being shared. So just I just put that link out there. But if you have not checked that out, you should. And if your institutions want to be part of that coalition, it's very easy to sign up as well.
Great. There's one more question about billing for ultrasound. It's come a couple of times. How does one bill for office ultrasound?
Yeah, I saw that question, and I did put a link on the chat window there as well that gives more information about reimbursement for, especially for point of care ultrasound. It's pretty unique, but having said that, there are lots of billing codes. So echocardiography, for example, there's specific billing codes as well. So that link has reimbursement guides for pain management and OBGYN and MSK and ICU and all of that as well. So I've included a link. I'll paste it again so you don't have to search for it.
Does anyone have any more questions? We have time for one more before these two people vanish into the dark. Okay, well, I would like to thank you very much, both of you. Rasu was an easy one to get, but I guess.
Hey, sorry, Archana, I have a question.
That's the last one.
Sorry.
Last question.
So I heard a couple of my friends back in India, they are using hydroxychloroquine for prophylaxis. So do you want to comment on that, or do you have any thoughts of what people back there are doing?
So yeah, I've heard of that as well. And, for us as a health system, we're not putting a stamp of approval on hydroxychloroquine. I think there's more studies yet to be done around that. So a lot of unknowns as such. What we've seen even in the last several days, weeks, are some adverse effects and side effects. So we're being cautious. I think there are more studies yet that need to be done around that. But clearly, I've heard of this from my colleagues back in India, or ex-colleagues back in India, as well as some specific studies that are being done elsewhere internationally too.
Okay, I know both of them are on the East Coast, and I think we'd like to wrap this up, just in favor of time for them. So I'd like to thank both of you, and if maybe we can do this at another time, some other time in the future as well, that would be greatly appreciated. Thank you, Anish, for taking your time. We know that you're an extremely busy person, and really appreciate you talking to us this evening.
Take care.
Anish, any final words from you?
Thank you. All good. Thanks you, everybody. I appreciate it very much. Stay safe.
You too.
Absolutely. All right. Take care, everyone.
Take care.
See you. Good night.
Bye.